Intraoperative care. Use of the nursing process during the intraoperative phase of care provides a framework for the delivery of care. The needs of the patient determine the type of care that you provide. These needs are based on the current health status of the patient and the type of surgical intervention anticipated. Advancements in surgical technology, improvements in the administration of anesthesia, and changes in the healthcare environment have changed where and how surgery is performed. The trend in surgical settings is a decrease in in-hospital surgical procedures and an increase in ambulatory outpatient procedures in hospitals, surgery centers, and physician offices. Differences in the ambulatory surgery setting as compared with the traditional in-hospital surgery setting include healthier patient populations and shorter procedures. You must keep current on technologies, maintain asepsis in the surgical environment, continue to be a strong advocate for the patient. As the population ages, the demand for some types of surgery, such as cataracts and joint replacements, is expected to increase rapidly. Specialties with the highest number of surgical patients, ophthalmology, gynecology, plastic surgery, otorhinolaryngology, orthopedic surgery, dental surgery, like for hernia repair. The presence of a family member or friend reduces the stress associated with the preoperative period. The certified registered nurse anesthetist is independently responsible for all aspects of the administration of anesthetic agents. Although the responsibility of a certified registered nurse anesthetist and an anesthesiologist have some overlap, the credentialing and roles are different. No supervision by a healthcare provider is necessary during anesthetic administration by a certified registered nurse anesthetist. They assess the patient and make the choice of anesthetic agent. Physical environment. Unrestricted areas are personnel in street clothes interact with those in scrubs. The holding area, the locker room. Information areas are the nurse's station, control desk. Semi-restricted areas are peripheral support areas with corridors with only authorized people. Must wear surgical attire and cover all head and facial hair. Restricted areas, operating rooms, scrub sink areas, surgical attire, head covers, and masks required. In addition, the physical layout is designed to reduce cross-contamination. The flow of clean and sterile supplies and equipment should be separated from contaminated supplies, equipment, and waste by space, time, and traffic pattern. Staff move supplies from clean areas such as the clean core through the OR for surgery and onto the surrounding areas such as the instrument decontamination area. The primary focus when setting up the OR is the prevention of cross-contamination and transmission of infection to the patient. Patient privacy, efficient completion of procedures, and smooth functioning of the OR team also are important, but the priority is protection of the patient from infection. Physical environment, also called the preoperative holding area. The size varies according to hospital design and can range from a centralized area to accommodate numerous patients to a small designated area immediately outside the actual room scheduled for the surgical procedure. Many minor procedures can be performed here as well. These include inserting intravenous catheters, arterial lines, and removing casts. Some types of regional anesthesia, such as the insertion of epidural catheters, may also be initiated in this area. Surgical Care Improvement Project measures to implement here patient warming, prophylactic antibiotic administration, and application of sequential compression devices. The operating room. Careful consideration of the design, location, and control of the physical environment assists with the prevention of infection and provides overall safety and comfort for the patient. Location allows for quick transportation of the post-operative patient and close proximity to anesthesia staff if complications should arise. Filters and controlled airflow in the ventilating systems provide dust control. Positive air pressure in the rooms prevents air from entering the OR from the halls and corridors. Ultraviolet lighting may be used as ultraviolet radiation reduces the number of microorganisms in the air. Dust collecting surfaces such as open shelves and tables are omitted. Materials that are resistant to the corroding effects of strong disinfectants are used. Adjustable, easy to clean, and easy to move furniture is used. Equipment is checked for electrical safety. Lighting provides low to high intensity for precise view of surgical site. Communication system is used. Extra staff and visitors are restricted from the OR to maintain patient privacy, prevent undue noise or distraction, and preserve the aseptic environment. The perioperative nurse. As the patient's advocate, you should assess the patient to determine any additional needs or tasks to complete before surgery to meet the patient's individual plan of care. Provide physical and emotional comfort and patient and caregiver education regarding the upcoming surgery. Work with the patient's caregivers by keeping them informed and answering questions. The nurse in the circulating role records all nursing care. Documentation may be written or electronic. Documentation of the assessment and identification of clinical problems, diagnosis, and intervention differentiates your role from that of other members of the surgical team. The sleeves of the sterile surgical gown are considered sterile only to 2 inches above the elbows, so touching the surgeon's upper arm would contaminate the nurse's gloves. Shoe covers are not sterile. Staff members, such as the circulating nurse, do not have to perform a surgical scrub before entering the OR. The surgical scrub nurse role includes maintaining asepsis in the operating field. The education and certification for a surgical technologist includes the scrub and circulating functions in the OR. Preoperative medical history and physical assessment, including need for surgical intervention, choice of surgical procedure, management of preoperative testing, and discussion of the risks of and alternatives to surgical intervention. The physician who performs the procedure. We have the surgical assistant, and in some institutions, the surgical assistant is a registered nurse or a non-physician who functions in the role of an assistant under the direct supervision of the physician. Hospital policies define this role and physician responsibility when a non-physician fills the assistant's position. May perform portions of procedure under direct supervision. The registered nurse first assistant provides exposure to surgical site, assists with homeostasis, and performs suturing. The registered nurse first assistant education programs are designed to provide the RNs with the education necessary to assume this expanded role. They can also obtain certification. The role of the registered nurse first assistant includes skills such as making and suturing incisions and maintaining homeostasis. Anesthesia care provider provides preoperative and adjunctive medicines, monitors cardiac and respiratory status and vital signs throughout procedure, maintenance of physiologic homeostasis throughout intraoperative period. Specific questions related to details of the surgical procedure and anesthesia may be referred to the surgeon or the anesthesia care provider. Before surgery, we have a chart review, history and physical, examination, urinalysis, CBC, serum electrolytes, chest x-ray, ECG. Cultural assessment is essential to understanding the patient's response to the surgical experience. For example, members of the Jehovah's Witness community may refuse blood transfusions. For Muslims, the left hand is considered unclean, so you should use the right hand to administer forms, drugs, and treatments. Physical assessment data that are specifically important to intraoperative nursing care include baseline data such as vital signs, height, weight, and age, allergies to food, drugs, and latex, integrity and cleanliness of skin, skeletal and muscle impairments, perceptual difficulties, level of consciousness, nothing by mouth, and any sources of pain or discomfort. You should provide explanations and reassurance, especially to the anxious patient. You can usually answer general questions regarding surgery or anesthesia. Examples of these questions include, when will I go to sleep? Who will be in my room? When will my surgeon arrive? How much of my body will be exposed? Will I be cold? When will I wake up? Admitting patients, complementary and alternative therapies are helpful to decrease anxiety, promote relaxation, reduce pain, accelerate healing process. Admitting patient, looking at reassessment, last-minute questions, review of chart, final questioning about valuables, prosthesis, contacts, and last intake of food or fluid. Room preparation. Electrical and mechanical equipment is checked for proper functioning. Aseptic technique practiced when placing the instruments. They have the counts. Functions of team members delineated. Before transferring the patient to the OR, you prepare the room to ensure privacy, safety, and prevention of infection. During room preparation and the procedure, the functions of the team members are clear. The scrub person performs surgical hand asepsis, dons a sterile gown and gloves, and touches only those items in the sterile field. The circulating nurse remains in the unsterile field and performs those activities that permit touching all unsterile items and the patient. Transferring patients, straps across the patient, caution with monitor leads, IVs and catheters, wheels locked. Nursing management. When a waterless product is chosen, you should first wash the thoroughly dry hands and forearms with soap and water. When the procedure of scrubbing is the chosen method of surgical hand antisepsis, often for the first case of the day, your fingers and hands should be scrubbed first with progression to the forearms and elbows. The hands should be held away from surgical attire and higher than the elbows at all times to prevent contamination from clothing or detergent suds and water from draining from the unclean area above the elbows to the clean and previously scrubbed areas of the hands and fingers. The sterile gown and gloves are put on after a scrub. Wearing street clothes into the nurse's station. Wearing a surgical mask into the holding room. Putting on a surgical mask, cap, and scrubs before entering the operating room. Protective equipment, face shield, caps, gloves, aprons, and eyewear. The corridors outside the OR are part of the semi-restricted area where personnel must wear surgical attire and head coverings. Surgical masks may be worn in the holding room, although they are not necessary. Street clothes may be worn at the nursing station, which is part of the unrestricted area. Wearing a mask and scrubs is essential when going into the OR. Assisting anesthesia care provider. Remain at patient's side to ensure safety. These responsibilities may include obtaining blood pressure measurements and assisting in the maintenance of the patient's airway. During the surgical procedure, you also provide a vital communication link for the anesthesia care provider to ancillary departments such as the laboratory or blood bank. Smoke particles produced during laser procedures may contain trace hydrocarbons like acetone, isopropanol, formaldehyde, and cyanide. These airborne contaminants can cause respiratory irritation and have mutagenic and carcinogenic potential. Smoke evacuators may be used to minimize this exposure. Care must be taken with correct placement of the grounding pad and all aspects of the electrosurgical equipment to prevent injuries from burns or fire. Preventing the wrong site, wrong procedure, and wrong surgery has become known as a universal protocol. Positioning a patient. It is to prevent injury. Patient will not feel pain impulses because of anesthesia. Secure extremities. Provide adequate padding and support. General anesthesia causes peripheral vessels to dilate. Position changes affect where the pooling of blood occurs. If the head of the OR bed is raised, the lower torso will have increased blood volume and the upper torso may become compromised. Hypovolemia and cardiovascular disease can further compromise the patient's status. The patient with arthritis may require special positioning to avoid injury and postoperative discomfort. Preoperative anxiety and having a sip of water 2 to 3 hours before surgery are not unusual for the preoperative patient. After preparation of the skin, the sterile members of the surgical team drape the area. Only the site to be excised is left exposed. Preparing surgical site, scrubbing or cleaning around the surgical site with antimicrobial agents. Circular motion from clean to dirty area. Hair may be removed with clippers. After surgery, the anesthesia care provider and the perioperative team member take the patient to the PACU and give report. Perioperative nursing data set reflects standards of nursing care in any perioperative setting. Intro to anesthesia. Although anesthetic techniques and agents are selected by the anesthesia care provider in collaboration with the surgeon and the patient, the ultimate responsibility for the choice of anesthetic remains the responsibility of the anesthesia care provider. Factors contributing to the decision include the patient's current physical, mental, and emotional status, allergy and pain history, expertise of the anesthetist, and factors related to the operative procedure such as length, position, site, and discharge plan. The anesthetist obtains anesthesia consent and writes orders for the preoperative and postoperative medication and assigns the patient an anesthesia classification. Total intravenous anesthesia and newer inhalation agents exhibit a fast onset, fast elimination, and fewer side effects, facilitating early discharge from the PACU in ambulatory surgery centers. General anesthesia. Additional reasons for general anesthesia include refusal of local or regional techniques, contraindication for other techniques, and uncooperative patients secondary to intoxication, lack of maturity, emotional lability, head injury, or inability to remain immobile for any length of time. A balanced technique using adjunctive drugs to complement the induction is the most common approach used for general anesthesia. Virtually all routine general anesthetics begin with an IV induction agent, whether it is a hypnotic, an anti-anxiety, or a dissociative agent. When used during the initial period of anesthesia, these agents induce a pleasant sleep with a rapid onset of action that patients find desirable. A single dose lasts only a few minutes, which is long enough for a laryngeal mass airway or an endotracheal tube to be placed. Once this is done, the anesthetist introduces the selected inhalation and IV agents. Recent advances in IV hypnotics and opioids have led to more frequent use of total intravenous anesthesia. All medications are delivered intravenously. This eliminates the need for inhalation agents. However, the patient may still require advanced airway management and will receive oxygen and air mixtures via this tube. The first step in general anesthesia is the injection of the intravenous IV induction agent, which rapidly induces sleep. The anesthesiologist, not the surgeon, determines the method of anesthesia use. Masks may still be used for inhalation, although many patients are intubated. Total IV anesthesia may be used for some patients, but inhalation anesthetics also are commonly used. IV sedatives such as benzodiazepines are administered for monitored anesthesia care. These agents may be volatile liquids or gases. Volatile liquids are administered through a specially designed vaporizer after being mixed with oxygen as a carrier gas. This gas mixture is then delivered to the patient via the anesthesia circuit apparatus. Waste gases are removed using negative evacuation pressure, venting to the outside of the institution. One undesirable characteristic is the irritating effect of inhalation agents on the respiratory tract. Each agent has its own specific characteristics, including the degree of respiratory tract irritation. Possible complications include coughing, laryngospasm, which is a muscular constriction of the larynx, bronchospasm, increased secretions, and respiratory depression. Newer, less soluble agents like Suprain provide for faster induction and recovery from general anesthesia. Once the patient has been induced with an IV agent, the choice for delivery of inhalation agents is usually through an endotracheal tube or laryngeal mass airway. Laryngeal mass airways are currently an important option for patients with difficult airways, but they do not provide tracheal isolation with the same certainty provided by endotracheal tubes. Complications of endotracheal tubes or laryngeal mass airway use include those primarily associated with insertion and removal. The administration of general anesthesia is rarely limited to one agent. Drugs added to an inhalation anesthetic other than an IV induction agent are termed adjuncts. These agents are added to the anesthetic regimen specifically to achieve unconsciousness, analgesia, amnesia, muscle relaxation, or autonomic nervous system control. Adjuncts include opioids, benzodiazepines, neuromuscular blocking agents, muscle relaxants, and antiemetics. It is important for you to know that these drugs are often given in combination and may have synergistic or antagonistic effects. You may observe deeper levels of sedation or more drug-related side effects beyond those seen with inhalation anesthetics alone. Opioids, sedation and analgesia, induction and maintenance intraoperatively, pain management postoperatively, respiratory depression. Benzodiazepines, premedication for amnesia, induction of anesthesia, monitored anesthesia care. Neuromuscular blocking agents, facilitate endotracheal intubation, relaxation and paralysis of skeletal muscles, interrupt transmission of nerve impulses at neuromuscular junction, classified as depolarizing or non-depolarizing muscle relaxants. Duration of effects may be longer than the procedure. Reversal agents may not be effective in eliminating residual effects. Observe closely for airway patency and adequacy of respiratory muscle movement. Lack of movement or poor return of reflexes and strength may indicate need for ventilator. Since ketamine causes profound analgesia lasting into the postoperative period, larger doses of analgesics are not needed. Ketamine causes an increase in heart rate. Benzodiazepines used with ketamine may be used to decrease the incidence of hallucinations and nightmares. Antiemetics prevent nausea and vomiting associated with anesthesia. Dissociative anesthesia interrupts associative brain pathways while blocking sensory pathways. The patient may appear catatonic, is amnesic, and experiences profound analgesia that lasts into the postoperative period. Ketamine is commonly administered dissociated anesthetic. Ketamine, administered IV or IM, is a potent analgesic and amnesic. It is used in asthmatic patients undergoing surgery because it promotes bronchodilation, and in trauma patients requiring surgery because it increases the heart rate and helps maintain cardiac output. Because ketamine is a PCP derivative, the drug may cause hallucinations and nightmares, greatly limiting its usefulness. Concurrent use of midazolam has been found to be effectively reduce or eliminate hallucinations associated with ketamine. You should provide a quiet, unhurried environment in the PACU for all patients receiving dissociative anesthesia. General anesthesia can be administered to patients with malignant hypothermia as long as the precautions to avoid malignant hypothermia are taken and preparations are made to treat malignant hypothermia if it does occur. Other factors besides acetylcholine administration are associated with malignant hypothermia. Local anesthesia interrupts the generation of nerve cell impulses by altering the flow of sodium into nerve cell through cell membranes. Volume and concentration of local anesthetic agent will, in accelerating fashion, block first autonomic, then somatic sensory, and last somatic motor impulses. The result is autonomic nervous system blockade, anesthesia, and skeletal muscle flaccidity or paralysis. Because volatile liquid inhalation agents are rapidly metabolized, postoperative pain occurs soon after surgery. Hypertension and tachypnea are not associated with general anesthetics. Myoclonia may occur with non-barbiturate hypnotics, but not with the inhaled inhalation agents. Administration of a local or regional anesthetic may involve concomitant use of moderate sedation, either pre-injection or intraoperatively. Regional blocks are now used as preoperative analgesia, intraoperatively to manage surgical pain, and postoperatively to control pain. In ambulatory or outpatient procedures, you may assist a physician in the administration of a peripheral or regional block. Consequently, you must be familiar with the drugs, the methods of administration, and the adverse and toxic effects of the drugs. Initial assessment of the patient should include detailed questioning of the patient's history with local anesthetics and any adverse events associated with the use of local anesthetics experienced by the patient or blood relatives. Many patients report allergies to local anesthetics. Although true allergies to local anesthetics occur, they are rare. Allergies are likely to be a result of additives or preservatives in the preparation. Many local anesthetics are combined with epinephrine solutions. They may be absorbed in the tissue or may inadvertently be injected IV, which enters the general circulation and causes tachycardia, hypertension, and a general perception of panic. Two classes of local anesthetics are available, esters and amides. It is highly unlikely that an individual is allergic to both. Local and regional anesthesia has little systemic absorption, rapid recovery, little residual hangover, possible discomfort, hypotension and seizures, and technical difficulties. Advantages of local and regional anesthesia include rapid recovery and discharge with continued postoperative analgesia without accompanying cognitive dysfunction. Patients with comorbidities that would preclude general anesthesia are now offered surgical solutions with increased safety. Disadvantages of local and regional anesthesia include technical difficulties, discomfort at the injection site, and inadvertent vascular injection leading to refractory hypotension, dysrhythmias, and possible seizures. Finally, the ability to precisely match the duration of action of the agents to the duration of the surgical procedure is a limiting factor. Classifications of anesthesia. Topical applications with or without compression of creams, ointments, aerosols, and liquids are standard method of administration. The agent is applied directly to the skin, mucous membranes, or open surface. When a patient is prepared for regional anesthesia, airway equipment, emergency drugs, and a cardiac monitor defibrillator should be immediately available to provide advanced airway and cardiopulmonary support if needed. IV injection of the agent and excessive absorption of bupivacaine in particular may lead to cardiac depression, severe dysrhythmias, or cardiac arrest. Examples of common regional nerve blocks include brachial plexus, IV bear block, femoral, axillary, cervical, sciatic, ankle, and retrobulbar blocks. You can facilitate the success of regional anesthesia by assisting in patient positioning, monitoring vital signs during block delivery, and administering oxygen therapy, and obtaining supportive devices at the direction of the anesthesia care provider used to contribute to the anesthesia, like ultrasound imaging, neurostimulator, tourniquets. For example, the beer block requires a double cuff tourniquet whose functioning is vital to the safety of the patient. Classification of anesthesia. Patients experience vasodilation and may become hypotensive as a result of the autonomic block and may feel no pain as a result of the sensory block and may be unable to move as a result of the motor block. The duration of action of the spinal anesthetic depends on the agent selected and the dose administered. A spinal anesthetic may be used for procedures involving the extremities, like joint replacements, and for lower gastrointestinal, prostatic, and gynecologic surgeries. Epidural anesthesia may be used as a sole anesthetic for a surgical procedure, or a catheter may be placed to allow for intraoperative use with continued use into the postoperative period to provide analgesia. This method of postoperative analgesia uses lower doses of epidurally administered local anesthetic and usually in combination with an opioid. Epidural anesthesia is commonly used for analgesia with general anesthesia in obstetrics, vascular procedures involving the lower extremities, lung resections, and renal and mid-abdominal surgeries. The desirable effects of vasodilation and analgesia contribute to better surgical outcomes. The most serious adverse effect of the neuromuscular blocking agents is weakness of the respiratory muscles, leading to postoperative hypoxemia. Physiological changes in aging may alter the patient's response not only to the anesthetic, but also to blood and fluid loss and replacement, hypothermia, pain, and tolerance of the surgical procedure and positioning. The older adult's response to all anesthetic agents must be carefully monitored and the postoperative recovery assessed before the patient is transferred from the PACU to a surgical unit. Many older adults experience a decrease in their ability to communicate and follow directions as a result of alterations in vision or hearing. These factors pose a special need for clear and concise communication in the OR, especially when preoperative sedation is combined with already existing sensory deficits. Because of decreased ability to perceive discomfort or pressure on vulnerable areas and loss of skin elasticity, the skin of the older adult is at risk for injury from tape, electrodes, warming and cooling blankets, and certain type of dressings. In addition, pooling of solutions used to prepare the skin in dependent areas can quickly create skin burns or abrasions. The older adult often has osteoporosis and osteoarthritis. Misalignment, pressure, or other insults to arthritic joints that may become desensitized from administration of anesthetic may create long-term injury and disability. Older adults are also at a great risk of perioperative hypothermia. The use of a variety of warming devices should be considered and carefully monitored if used. Catastrophic events in the OR. Anaphylaxis is the most severe form of an allergic reaction, manifesting with life-threatening pulmonary and circulatory complications. Anesthesia care providers administer an array of drugs to patients such as anesthetics, antibiotics, blood products, and plasma expanders. Because any parenterally administered material can stimulate an allergic response, vigilance and rapid intervention are essential. An anaphylactic reaction causes hypotension, tachycardia, bronchospasms, and possibly pulmonary edema. Antibiotics and latex are responsible for many perioperative allergic reactions. Latex allergy has become a particular concern in the perioperative setting, given the use of gloves, catheters, and many other devices containing natural rubber latex. Reactions to natural rubber latex range from urticaria to anaphylaxis, with symptoms appearing immediately or at some time during a surgical procedure. Latex allergy protocols should be set up in each institution so that a latex-safe environment can be provided for susceptible individuals. Catastrophic events in the OR. Malignant hyperthermia often occurs with exposure to acetylcholine, especially in conjunction with inhalation agents. Usually occurs under general anesthesia, but may also occur in recovery. Other triggers are trauma, heat, and stress. Malignant hyperthermia can be an inherited hypermetabolism of skeletal muscle resulting in altered control of intracellular calcium, tachycardia, tachypnea. So the definitive treatment of malignant hyperthermia is prompt administration of dantrolene. Dantrolene slows metabolism, reduces muscle contraction, and mediates the catabolic processes associated with malignant hyperthermia. A treatment protocol available from the Malignant Hyperthermia Association of the United States is often displayed in the OR. To prevent malignant hyperthermia, it is important for you to obtain a careful family history and be alert to its development perioperatively. The patient known or suspected to be at risk for this disorder can be anesthetized with minimal risk if appropriate precautions are taken. Patients with malignant hyperthermia should be informed of the condition so that family members may be genetically tested.